My name is Tamara Solem, and I am an Exceptional Needs Care Coordinator with Kaiser Permanente presently. And as a care coordinator, I know that we are at a really unique moment. There are so many opportunities now for partnership to improve the health of our communities. It is truly a great and inspiring moment. But at the same time, as both diversity and economic inequality increase, the stage can be set for conflict, and it can be challenging out there. And that's even as we strive for greater equity and to address the disparities encountered by the folks that we work with. So what is our role as care coordinators and individuals? How do we engage within our systems and interface with each other in ways that build equity and inclusion? And why does it even matter? Dr. Mason is here to address some of those questions. His background is both broad and deep. He has conducted health and human services research since 1985 and consulted throughout the United States, Latin America, and Canada on issues of workforce diversity and culturally competent service delivery. He is also the former director of the Office of Multicultural Health for the state of Oregon and one of the founders of the National Association of State Offices of Minority Health. He is a founding member of the National Center on Cultural Competence at Georgetown University. More recently, he served as Chief Diversity Officer for Providence Health and Services here in Oregon. Currently, he is founder and CEO of Organizational Cultural Competence Consulting and Training. He is also a personable and engaging speaker. We are so fortunate to have him here this morning. So please join me in welcoming Dr. Mason.
Good morning, everyone. First, I want to thank Tamara for the lovely introduction and the embarrassing bio. My mom loves to hear it whenever she can.
She called me.
She called you? But I said good morning, and something I would have you think about, whether you are a good morning person or greeting person or not, is learn to greet. It is so critical to the work that you do, and we heard Dr. Davis talk about trauma-informed care. If people have been dissed or mistreated or treated funny in their lives and they walk in the room and they say hello or they nod at you and they don't get it back, it means something very, very significant to them, whether you meant for it to or not. So learn to greet whether you are a greeter or not. And the greeting doesn't have to be significant or anything like that. It's just, hey, what's up? Just a word to the wise. It can get prolonged or protracted, so be very, very careful. But learn to greet. Today I'm going to talk about a few things, and I'm going to, I really appreciate hearing Dr. Davis's comments and trying to make a very complex kind of concept comprehensible by normal people. The other thing that she said that I was really taken by, and something I would have you also think about, is while you're fixing the world and taking care of the world, make sure you're taking care of yourselves. Something I've seen everywhere with do-gooders and caregivers is that they are very, very good at taking care of others, but meanwhile their fence is falling down, right? Or their car is not working, or they're not working, or something like that. So learn to take care of yourself. That's going to be absolutely critical, I would argue. Something I would have you think about in the interface of dealing with diversity and difference and things of that nature, or just difficult conversations, is don't be afraid to establish ground rules before you have the difficult conversation. We all have heard them, we've all seen them, but something I found to be absolutely critical in working in the types of areas that we do is the idea of assuming positive intent. And that's something that we do with the people that we work with. On the other hand, we take responsibility. We assume they mean well, whether it comes out well or not. I'll give you an example. Years and years and years ago, I was doing a workshop. It was all day. It was an elder group here in Portland. It was Saturday. I was trying to get through, and around 4:30, I was winding down. My batteries were running low. And you do this obligatory thing at the end of workshops. You ask, are there any questions, right? And you don't really want any questions, but it's a polite thing to say, right? And I said, are there any questions? And a hand went up. And I'm like, oh. And I said, do you have a question? And she said, nodded yes. And the person next to her pulled her hand down and said, but you don't want to hear it. And I'm like, oh, okay. And I moved on, and her hand popped back up. I said, do you really have a question? She said, yes. And a friend pulled it down and said, but you really don't want to hear it. And it was, 4:45. How bad could it be? 85-year-old woman. My audience is all white. What can happen, right? And she said, is it okay to call you people the N-word? Now, she didn't say the N-word. She said the N-word, right? And the coolest thing about that was my white audience went red at the same time. And I thought that was the coolest thing I've ever seen in my life, right? I was like, damn, I didn't know they could do that. And you know what? And the question was, gross as all get out, but sincere. And I didn't know really what to say other than, yeah, if you run fast enough. But the idea there was, she finally had the opportunity to ask someone, and she asked me, and so again, what you're going to find in the work that you do, you're going to get asked the funny stuff. You're going to get accused of the funny stuff. Assume that they mean well. In your own instance, take responsibility. You're going to do something awkward and very unintentional. You're going to call someone who identifies as African American black, or someone who identifies as Native American as indigenous person. Are you going to misuse a pronoun on someone? And they're going to blow your hair back, right? In your heart, know that you meant well, apologize, and move on. You don't get to make that mistake again, but you do get to make a mistake again. So life is good in that way. There we go again. These are the questions I would have you wonder about in the work that you do. And the first one is, how well are you able to, what drives your concern for cultural and linguistic competence and workforce diversity? And I'll walk through a few examples before I get to what I really want to talk about today. But I found this to be very, very important to sustaining your efforts toward diversity, toward trauma-informed care, dealing with the chaos. Why are you doing it? And ultimately, it distills down to being in your best interest. If you want to be the best you can be, you do this. And I'll walk through that with you for very, very briefly. The other thing are the types of, how well are you able to describe the diverse groups you work with? Tamara talked about me traveling everywhere, and I did at one point. I'm trying not to anymore, but often I will get calls and they will say, James, can you come talk to us about diversity? And I would say, sure. I said, like what? They said, like diversity. I'm like, sure, but like what type of diversity? Like diversity. I said, well, okay, I can do that. I said, well, who are you serving? I said, we're serving some black people. I said, like, what kind of black people? And they say, like, black people. And I'm like, okay, I can do that. What I'm suggesting to you is, how deep are you able to go with the people you work with? The food groups aren't very, very descriptive. What does black, white, Latino, Asian, Native really mean in the 21st century without some qualifiers? And as Dr. Davis alluded to, without some of the stressors in their lives that can impact such things as trauma, or impact how they seek help, and things of that nature. We'll walk through that very, very briefly. And the last question is, where do you go? To what extent do you have contacts who help you know? And my suggestion to you would be, make sure that as you develop your contacts, your linkages, that you get more than one. That you don't want to just have one person tell you what all this group does. Give an example. Years and years and years ago, I worked at a research institute, and I got to work, and it was Monday morning, and you drag into work sometimes Monday morning, and you don't really want to be there, and you walk in the lobby, and all your friends are standing there, and they're like, oh my God, James, we're so glad you're here. You're the only one we could ask. And all my white friends were there, right? And I'm like, okay, this can't be good. And I remember it was during the OJ era. And someone asked a real funny question, like, blah, 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 blah. Why did OJ do all that? I was black then, so I felt compelled to answer. Right. But I didn't know, right? And they were all looking at me, and so I just started making stuff up. And you ever start making stuff up, and the story gets kind of good to you, and you just keep going, and I was like, whoa. And I was like having fun, and they said, that is so deep. I said, you don't even know, right? But I did say to them, help me now. Thinking of white people, why did Jeffrey Dahmer eat those folks, right? And again, it was one of those red moments where all my friends turned red again, and I said, and they said, why would you even ask us that? And I'm like, why would you ask me about OJ? I'm not allowed to speak for the 5 black people in my immediate family, let alone 35 million in the US. So my point is, as you develop your contacts, make sure you get more than one. Critical mass is going to be critical. Otherwise, they'll make it up on you and you'll just be in a bad place. These are some of the rationale for why we do the cultural competence thing. And irrespective of your model, it can be the cultural responsiveness, it can be CLAS, it could be cultural humility, it could be, there's so many different definitions. Most of the nuances, the real nuance around these models is that they're behavioral. The earlier models were cultural awareness. What do we think? What do we know? Now we're compelled to what do we do? And we'll talk about that as we go forward. But some of the reasons we're doing this is the demographic shifts. We can just think of the metro area, how Portland has changed significantly over the last 20 years. When I got here 30 years ago or so, I finally found our little hood. We had a little hood over in northeast Portland, which I thought was kind of cute, coming from LA, because it's predominantly white. I'm like, wow, damn, this is an interesting hood. But what it was about 90% of Oregon's African-American population was concentrated in one area. So if part of your agenda was working with African-Americans, you had economy of scale, and it could happen fairly easily. If we look at what's happened over the last 20 years, they've been spread to hell and gone, right? So now you find them. You find them everywhere. You find them everywhere, damn it. I know I'm going to hell. But you find them everywhere. And we're finding them in areas where we haven't had the history of serving them, educationally, in terms of law enforcement, child welfare. So again, we can also think of not only the disbursement of a group, but we can think of how an area might shift. If we think of Beaverton 20 years ago, it was the vanilla side of the river, quite frankly, right? You want to see white people, you went to Beaverton, right? And if you talk to Mayor Doyle today, Mayor Doyle will tell you that Beaverton is the most diverse city in Oregon. Washington County, perhaps the most diverse county in Oregon. We used to be smug on the east side, thinking we're the most diverse and the coolest and the funkiest, and now we're the most rapidly gentrifying. So again, we can think about demographics in that way. And we'll talk more about demographics later, but just being aware of how your environment is changing. Who's here that wasn't here? And we'll talk about that. Culturally diverse belief systems. We're learning more about that. How people view illness and health. Dr. Davis talked about, was alluding earlier, the idea of rapport, relationship, which is critical to working cross-culturally. And often we are so busy that we often fail to have time to connect with people. People for whom time might matter more than people. People might matter more than time. I'll give you an example. I used to live across the street from my mom's best friend, Miss Shirley. Miss Shirley was a retired teacher, teacher's aide, African-American. She was my mom's age, mom's best friend, lived across the street, and she would didn't have a car, and she would call me, ask me to take her anywhere, anytime. One morning she called around 7:45, asked if I would take her to Safeway and bring her back home. I said, no, Miss Shirley, I'll be late. She said, that's okay. You'll run me there, I'll run in, I'll run out, and then you run me back home. Miss Shirley is about 5 feet tall, 350 pounds. She doesn't run anywhere, right? I love her to death. But I said, Miss Shirley, I'll be late. I really can't do it. She says, it's okay. I'll be waiting on my porch. I have two doors. I had two doors to the house, and so one door I could sneak out without her seeing me, and I did. And I got in my car and went to work. And I got to work, and my light was flashing on my phone. Miss Shirley, she says, I'm waiting on the porch. And the light kept flashing, and it was from my mom. My mom said, Miss Shirley's waiting on your porch, you need to go get her. And I called my mom and said, Mom, I will be late. She said, that's okay, you're gonna run her to Safeway, she's gonna run in, she's gonna run out, and then you're gonna run her back home, right? Miss Shirley comes from a culture where people matter more than time. I worked in healthcare. Time mattered more than people. There's a serious clash there. So again, when we think about how people operate, in many cases, we should let them know that we don't have the time to have the conversations that they want to have. We might have to orient patients to understand the work that we do. And when you can make time, I would argue to make time and learn. The other thing is illness and health isn't universal, how we believe. For example, there's often a moral view of health and illness, that one becomes ill if they've been bad. There's an ancestral orientation to illness. One becomes ill because an ancestor's been bad. And often these things are so cultural, so little thought of, but just belief systems. Are we imposing our belief system on them? And we'll talk about that as we go forward. Another reason we're doing this is to eliminate health disparities. We're also doing this because it's in the community's best interest. It's what we're paid to do. It also helps overcome our biases around our formal and informal education, who's worthy and who's not worthy. And this is really especially critical now. It's also tied to our accreditation, funding, and licensure. The other thing that I would have you think about is, because we put people in these food groups, understand that just because one is doesn't mean one is. As an African American, I could be an African American's best friend or worst dang nightmare. And often we put people of nationalities together thinking that it's going to be harmonious. We want to be careful that way because of the conflict within and between groups. Other thing I would have you look at is the impact of intergenerational poverty. And I think Dr. Davis alluded to epigenetics and the consequences that can come from being intergenerationally poor, which isn't necessarily cultural, so I want to make that distinction. I really don't believe in the culture of poverty. But often we find that people that have been intergenerationally poor might not eat the best, might not prioritize exercise, might not prioritize a time off and things of that nature. We want to be careful that we don't impose our middle-class, college-educated values on people that don't have that. Easy to do, easy to do. I was in a meeting one time and I remember someone saying that, I'm being videoed, so I gotta be careful. They were saying something like, poor people didn't care about their children's health. That poor people would rather buy a big screen TV than a health insurance policy. I was sitting in a room with people that all made six figures. If they didn't go to Maui or Cancun or Rome in a given year, they were butthurt, right? And the people that we're talking about may not go to the beach this year, may not go to the coast this year. So again, we want to be very, very sensitive in understanding how poverty affects how people make decisions and are forced to make decisions, but it isn't a cultural thing necessarily. Another thing that we want to be sure to understand is that a lot of people that we're working with, and Dr. Davis alluded to this in various ways, how do we ask them, how do we implicate them on policy-making boards and decision-making boards in critical numbers, so it's not just one? How do we empower them and grow them so that they're effective in our decision-making? It helps reduce liability and malpractice, helps address civil rights issues, make sure we don't get in trouble that way. And for many of us, we are in mission-driven organizations and it aligns with our mission and core values. So part of what I would suggest to you is, when you think about culturally competent care, what are the drivers for you? Why do you do it? What's important to you? How do you explain this up the food chain and down the food chain? And we found that the down the food chain thing to be very, very important lately, because we get a lot of people that are coming in to various clinics in various settings who might look down their nose at other people in the room. And in many cases, we had to explain why we're doing the cultural competence thing. Here's the other thing I would have you think about is workforce diversity. These are among the rationale, but again, when we think about why we're doing workforce diversity, it's in our best interest again, as organizations. The creativity, the productivity thing is absolutely critical. The idea of retention, absolutely critical. Too many reasons why we do this that are emerging in the literature and the research, again, in our best interest. And personally, I believe in a diverse workforce, but I also believe in a culturally competent workforce, and they're not necessarily the same thing. Not necessarily the same thing. So I believe in the rainbow look, and I believe in the rainbow effect. Here's the deal. We can all provide the rainbow effect. Years and years and years ago, I was doing a lot of work in MCH, maternal and child health, and often when I would go on the road or go places, I'd be the only kind of guy. I was a guy then as well. And I remember often I would get questioned as to why are you here? Shouldn't a woman be here? I'm like, yeah, it kind of depends on what you want. If you want the look, yeah. If you want the information, you want me. And what I've learned is who can work cross-culturally will surprise you. We all can. And we're all going to be required to if we look at the changing demographics. Our world is changing faster than our workforce. Who's in the professional schools, who's in the medical schools, it's not the people that are coming up in much bigger numbers. We're all going to be forced to do this. So again, something I would have you put in your own toolkit is understanding a rationale as to why you're doing cultural competence and a rationale as to why you're playing around with workforce diversity and how you help retain and advance people's, here's something else I would have you think about, are just the dimensions of diversity that you're going to encounter. Something that happened in healthcare in the last 8 years was we were now required to ask people their race, ethnicity, and language preference. Before that, we would look at them and guess what they were. That's hard to do in the Great Northwest because our son leaves us from what, September? to what, September, right? We racially intermarry in the Great Northwest, and that makes people a mess. And the example I often give, if you've been around newborns, looking at them, you can't tell, right? So we're now required to ask people what they are as a way of doing utilization reviews and making sure that our outcomes are approaching equity, or that we're getting better. And these are among the major groups that we work with. You see the first groups are basically racial groups. And the terms are very, very dynamic. And something we learned in asking people what they are is that within a given family, you might get variation on people's identify racially. We're also learning more about sexual identity and gender identity and things that are important with that. So again, when we think about diversity, understand that there are various ways to look at it. And something that I often get is that, Dr. Mason, you know diversity is more than race and ethnicity. And I'm like, yeah, I do. And it is. Let's not forget race and ethnicity. Dr. Davis talked about how hard it is for a lot of us to talk about race and ethnicity. It's hard to talk about race and ethnicity for a lot of people. Get used to it. And one of the beauties of a conference like this is to make sure that you leave with business cards. Leave with contacts that you didn't know, that you begin to build your network for the 21st century. Because if everybody in your group, your network, looks and thinks and talks like you, your ability to debrief the diverse is going to be limited. We see non-ethnic cultural groups here, and I just have a few of them. This is not an exhaustive list. Refugees and immigrants, and the distinction, refugees come for survival, immigrants for opportunity. And we see a bunch of stuff going, and I'm not being political at all, but we see a bunch of stuff maligning refugees and immigrant groups. And ultimately, what I would suggest to all of us is try to get to know the diverse populations from their strengths, their resiliencies. There's an old African proverb that you don't let the lion tell the zebra's story. From the lion's perspective, the zebra is meat, right? And not a whole lot more than that. One of the nuances we've seen is that as women tell their story, it might be different than having a man tell the story. As a person with a disability tells their story, it might be different than a person without a disability telling how they live their lives. Let's make sure that we are availing ourselves to the literature, availing ourselves to conferences like these, and availing ourselves to our colleagues who might have insights and our customers who absolutely have insights. I'm sorry about that. These are some of the internal factors that when I ask, like, what is white, black, Latino, what does that mean? Cultural and racial identity don't have to be aligned. So as I stand in front of you, I'm African descent, I'm black, but what you don't know is how black I am. And what isn't smooth is for you to say, how black are you? That's not a smooth thing to say. I probably would resist that, right? But in many cases, we might want to know who we're working with. Here's a funny thing that I teach our docs to do, is I teach them to ask, what kind of music do you like? What kind of food do you eat? What holidays do you celebrate? Those are questions we can ask on a first encounter. When you heard Dr. Davis talk about the importance of relationship, think about the questions we ask in the work we do. We'll ask people about their health history, their mental health history, their age, their sexual history, drug and alcohol history. We'll ask those questions with impunity. And when I was a provider, when I asked those questions, if they resisted, perhaps because, as Carol Anderson said, because of trauma, I would think something sinister was going on. And I would check that upper right-hand box, resistant, right? As I grew older, I learned that certain people don't share that information with strangers, right? I mean, here's something I want you to do, not today, not today. Next time you're at a mall or at a party, I want you to walk up to a stranger and do an intake. Ask them their mental health history, their sexual history, drug and alcohol history, health history. No, 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 no. If they start to answer you, get away. That's a sick person, right? And rarely do we explain why we have to ask these questions. And so part of the thing that we can do is we can ask questions that might endear people to us. Do they like pets? Do they like sunsets? Do they like the beach? Do they like kids? Do they like their own kids, right? All the kind of stuff that makes life kind of cool. And so while we're focusing on the differences that we might have with the people we're serving, are we foodies? Do we like puppies? Do we like sunsets? Do we like chocolate cake? Can we go there? And once the friendship is in place, once the relationship is in place, it's easier to make a mistake. They'll know it's an artifact of your dumbness and not your meanness. And that's a cool thing. That's a cool thing, believe it or not. So again, we think of the people we're serving, various ways to look at them: socioeconomic status, income, education, occupation. We look at nationality. We might call them Asian, but they might see themselves as Cambodian, and that might be a sense of pride. We might label them as black, and they might see themselves as Nigerian or Ghanaian, and that might be a source of pride. Understand that the native community, the different tribes are often a source of pride, and just being native isn't enough. Learn about language and communication style. And something that you might find very, very powerful is it's called ethnographic interviewing. Come from a background of mental health as a practitioner. And I learned the pensive nod a long time ago. And I use it when I don't have a clue, right? But it makes it look like you're deep, right? And being thoughtful, right? And so every now and then someone would say something to me, and I would, And my body was like, what the hell is going on here, right? What I learned to do is ask people, what does that mean? I've learned to wonder with them. And I found that very, very profound things happen. Typically, I'm the professional and they're not. When I ask them what's going on, we do this. They become the boss of me for a moment. It makes the relationship much more reciprocal. No one likes to be in a static relationship like this and always being the empty vessel, always being the one who benefits from your benevolence. We want to make sure that we can have people empower us. And I heard that so implicit in the words of Dr. Davis this morning, would just have you think that when you don't know, it's okay. And wonder with them. Wonder with them. A great example might be just trying to keep up with kids' slang, right? asking people, what does it mean? And the cool thing about slang, if you ever want to get rid of your kids and get them out of the house and their friends are over, just use bad slang around their friends and they'll get embarrassed and they'll leave. That's a practice-based evidence for you right there. Disability, how's it viewed by a given cultural group? Let's not just put our Western lens on it, of physical materialism that way. Family history, which is implicit with respect to trauma, help-seeking behavior, how they get to you. Generational status, generations American, generations English-speaking, generations urban, millennials versus boomers. Who are you working with? And can you go deep with them? So again, something I want you to try to do is be better at looking at the people you're serving. And these are some of the health determinants that you might find. The isms, racism, sexism, homophobia, ableism, classism. When I was listening to the Carol Anderson video this morning, I was thinking about growing up in a very, very working class family, poor family, and how clothes were something that were very, very important to me because I wanted to look appropriate wherever I went. And then when I moved to Santa Monica as a teenager, young teenager, adolescent, which was a very, very affluent area, just the trauma of being poorly clothed and in an environment where clothes and materialism was profound. I'm cool now. Dr. Davis says you can get better. I got better. Community economics. Understanding how the idea of joining a gym may be prohibitive. The idea of walking in their neighborhood at night when they get off of work may not be safe. And not everyone can live in an area where food safety or availability of food is assured. So understand who we're dealing with at a micro level and a macro level. What can we begin to do? There's some things I want to share with you before I have to get off and I've digressed so much. These are just some of the people that you might want to think about adding to your contact list. Faith-based organizations. Meet the clergy, the rabbis, the shaman, the priest, the pastors. Make sure that you have them on your network. And the first time you visit them and the first time you meet them, they may be somewhat standoffish. Be persistent. The advocacy groups. And the metro area has some great groups, such as APANO, such as Urban League, Latino Health Coalition, NARA, NEA, Basic Rights Oregon, among my friends. Make sure that they're part of your network as well. Understand electronic media, social media, how that might be something that you might be able to take advantage of in a big way in getting messages out. Print media is still around as well, particularly ethnic print media. Look at the merchants, the business alliances. Make sure that they're aware of what you're doing. Also, don't be embarrassed to ask them to be of help. And we see other groups that might be part of your networks that we want to add. So again, we asked the question, community contacts. And do you share them so that people don't have to learn the hard way? What can we begin to do? An action area is enhancing your cultural knowledge of the people you're serving. I talked about demographics. A simple thing that one can do as an organization is just post the demographics of your service area. You can download it pretty easily. In fact, if you want to see some contrast, look at the data from the 2000 census, the 2010 census, and what's projected in 2020. Look at the languages. Look at owner occupancy rates. Look at educational attainment. Be able to understand who you're serving. Build on cultural strengths and assets. Learn what people value, which might be their family, their faith, their history. Understand them in terms of their resiliencies and not just their deficits. Learn the languages and communication styles. Learn how to use interpreters if you must, effectively. Understand the health determinants and how you might be able to mitigate against those. And ultimately, what I would suggest to you, look for community leaders and trusted voices. I mentioned Ms. Shirley earlier, and even though she was an elder and a teacher's age. He wasn't didn't make a ton of money. She was very much a trusted voice in her community. And if she said something, it worked. Something else I would have you think about is community engagement. Do the Cinco de Mayo, do the Pride events, do the disability events, do the senior events, do the MLK events. Be seen. If you can, wear your office regalia, wear your badge, wear your company hat, whatever. You want the relationship before you need the relationship. And the first time you come, they may wonder why you're there. Second time you come, they say, my God, they came back. And the third time, it might engender the conversation. Have the conversation. It's going to be essential. Something else I would have you think about is creating patient orientation materials. With the advent of again, not being political, Obamacare perhaps, ACA I guess is what I should have said, we had a lot of people having health care for the first time. And a lot of people prior to that, the way that they sought health services was through the emergency room, inappropriately. A lot of health systems had to teach people how to access their clinics, urgency care facilities, and things of that nature. Something else we might want to think about is making sure that as our patients come to us, that they're respectful in the waiting room, and they know what their wait times might be like. And they know the etiquette that we will try to display. Something I've heard a lot about lately has been patient behavior where patients don't want a certain ethnicity providing care, or they don't want to sit in a waiting room with a certain type of people. We might have to explain to them why that might have to be tolerated. And there's an interesting book by Damon Tweedy. Dr. Tweedy is a psychiatrist at Duke Medical School, and the book is entitled Black Man in a White Coat. And he talks about the trauma that he had as a provider when he had a white family that didn't want him he was African American, as their therapist, and how he would be pulled off the case. And the other thing that he said was there were times when African Americans would come in and didn't want a white provider, but they didn't have enough black providers. So it was hard to start doing that matching game, and in many cases it's very inappropriate. And you'd be surprised, some people are very adept at working cross-culturally. Identifying or acting upon community priorities. If we think of the health determinants, for example, can our organizations or can we be members supporting their efforts to enhance health care, enhance drinking water, and things of that nature? Something else I would absolutely say is critical for you is in treatment planning and we heard, again, Dr. Davis alluded to this, the idea of creating systems of care, comprehensive systems of care, culturally competent systems of care. I told you my days as a therapist, client would come in and I was trained to say, how are you doing? Client would say, good, but cold and hungry. I do the pensive nod. I said, how does it make you feel? Client would say, cold and hungry. I would say, go with that a bit. And the client would go, cold, hungry, right? What I found was, if I didn't play the cold and hunger game, they weren't going to play my mental health games. The priorities that I had weren't necessarily their priorities. So a big thing that we want to make sure that as people come in, can you broker a winter coat? Can you broker a food basket? Can you broker a DV shelter? Can you broker a job referral? Can you broker a bus pass? Things that matter if you want to be loved. So again, what I would suggest to you, an area where we can all begin to grow ourselves is engaging the community. And I'm looking for my timer.
I thought you saw me, sorry.
I did see you. You're having too good a time to be a timer. And these sounds are just something else. I talk about sharing cultural key informant networks. Something I found in organizations is that people tend to learn the hard way, very arithmetically, 1 + 1 + 1 + 1. Part of what I'm going to ask you to think about is, can you create a cultural corner in your staff meeting, where every now and then we ask, are there any insights? And we share some of the breakthroughs we've made, some of the knowledge we've made around working with seniors, people with disabilities, people of color, LGBTQ, immigrants and refugees. Something I found is that organizations tend not to share that. And the fact is, what we tend to talk about is gallows humor. You know they're always late. You know none of them speak English, right? You know they always bring their family. Let's share some of our cross-cultural insights. Let's expedite learning that way. Utilizing cultural and community-based resources and systems of care. The interesting thing is that if you're creating systems of care and you're working with someone who may be LGBTQ and you send them to an environment where the service being provided isn't all that LGBTQ friendly, they might resist that service that you broker to them, and they might resist you. Our credibility is only as strong as our weakest link. Now, if there are going to be times when you need to broker that service, give them the heads up that they're barbarians, but we need what they have to offer, is okay to say. Here's something else we can begin to think about doing, and this is something I would have us all think about, is how we begin to prime the pump for 21st century talent. One of the things I was really proud of it, among the work I was able to do at Providence, we did an interactive comic book that was around healthy behaviors. But a part of the storyline was our docs were telling little young people to do STEM careers, go into healthcare. If we're trying to break the cycle of poverty and stuff like that for people, don't be afraid to steer people toward STEM careers. It's going to be absolutely critical for their future. Again, something else you might find to be helpful as you try to get the message out about a service you offer or something to that effect. Don't be afraid to have someone broker the message for you. A merchant, an elder, a faith-based entity. They might be much more credible. Here's something else to think about. As we bring on new people, let's make sure that they are prepared for diversity and the work that we do. They're going to be an asset, irrespective of what they are. When I taught at PSU, most of my students were white. I'd probably say 90% were white, if I were to guess. And most of them were interested in diversity. But they often didn't look the part. What's interesting is a lot of my friends of color have become diversity people, even though that wasn't something they studied in school or were interested in, almost by default. Something I try to do whenever I can influence hiring, I ask people to ask whoever they're bringing on board about their willingness, desire, or experience working cross-culturally. We want to make sure that whoever we bring on board, whoever we hire, whoever we even bring on as interns, are ready to be diversity assets, ready to help us grow with us. So again, something I would suggest to you is learn to make sure that our staff are aligned around diversity. Something we also need to be thinking about if you're an administrative role at all is updating policies around your mission statement. Does it have diversity statements in there? Does it talk about equity, or is it dated? Something else we might want to make sure that we begin to do is find venues where we can promote the health services that we offer for seniors, for people with disabilities, for people of color, and understanding that we might not get the critical mass that we might need. Something Dr. Davis said that we don't do enough, and I find to be critical, is asking people what they need. A big part of my life was spent doing collaboration with consumers, movements around the country. Would really ask you to look for ways to involve consumers on your advisory boards, and your clinical reviews, and things like that. It's probably the most under-tapped resource are consumers and former consumers. Here's something else I would have you think about is, as you think about training needs, don't presume what they are, try to assess what they are. That's something that I've been doing for a lot of years. When people ask me to come in and do training, we want to make sure that what we offer makes sense. Building on community norms and natural supports. Meeting times. Can you bring someone with you? Are you on a bus line? Things of that nature. Orienting clients with respect to services. In many cases, A lot of people may not know what we do. Let's make sure we're getting the word out. Let's be considerate of health determinants in treatment planning. Let's individualize care. Something else we might want to do is review outcomes periodically. See if we're having similar outcomes across differences. Are there geographical differences in our outcomes, age differences in our outcomes, ability differences in our outcome, racial, ethnic, gender, sexual differences in our outcome? We need to know that. And again, making sure that, to the extent that we can, creating supports for our staff to work cross-culturally. Something I was real proud of that we did at Providence and most of our facilities was we did brown bags. We were able to pay people a very, very small stipend to talk about what they enjoyed about our care and what could be better. In many cases, we had to prime the pump by developing questions or telling what they might talk about. But we found that to be a very, very powerful tool in, number one, our learning and assuring that they were getting the word out for us. Staff development, refining recruitment and retention, looking at fit in a different way that is not based on necessarily gender or age or education or where they went to school, but do they like families? Do they like potlucks? Will they be part of the team and things of that nature? So we're looking at fit in a different way. Make sure that we onboard people. And we provide, to the extent possible, mentors and guides. Utilizing community-based organizations as potential referral sources, consumers as potential referral sources. And again, thinking all the time of aspiring to workforce diversity, equity, and inclusion. Something else we found to be really, really critical that I would have you all begin to think about is the idea of managing conflict. As we become more diverse in any way you define it, conflict is likely enhanced. So can we manage conflict? Something we did, we were offered at Providence and elsewhere, was the unconscious bias training and interrupting bias training. How do we stop it when we hear it? But we found that to be critical along with managing cross-cultural conflict. Again, some of your resources are going to be faith-based organizations and clergy. It's going to be advocacy groups. I've talked about media, things of that nature. Don't overlook this. Thank you very much. Before you leave, what I would absolutely say to you, and I think this is perhaps the most important part of cultural responsiveness, or working cross-culturally, or being good at what you do, is wherever you are today, the goal is to be better tomorrow. The other thing I would have you think about is purely an N of one. You don't want to compare yourself to another person. You want to compare yourself to yourself over time. One of my favorite theorists is Daryl Sue. And in his book, he's written extensively about microaggressions and working cross-culturally and counseling culturally different. And something he said that I think is absolutely should be a gift to all of us is that this is a developmental process. Be better tomorrow. The world needs you. It especially needs you now. And I'm going to say make sure that you're taking care of yourselves and each other. Thank you for being an attentive group and listening this morning. I wish you well. Do great things in the world. Thank you very much. Take care.